Earlier in 2018, at the AACR meeting, and along with a coincident New England Journal publication, the Keynote 189 trial was presented and published. And this study looks at a combination of cisarcarboplatin with pemetrexed and pembrolizumab versus the same chemotherapy alone in patients with advanced non-squamous non-small cell lung cancer who don't have an EGFR mutation or ALK rearrangement. This was irrespective of any degree of PD-L1 expression. And it demonstrated not only a significant improvement in overall survival for chemoimmunotherapy with this regimen compared to chemo alone, but a highly significant improvement with a hazard ratio of 0.49. And this really held up really in all of the groups, regardless of PD-L1 expression. The benefit was strongest in the patients with the highest level of PD-L1, but it was still present in those with lower level PD-L1 as well. What was interesting is that at ASCO 2018, there was another presentation of Keynote 407, a very similarly designed study in squamous non-small cell lung cancer, and with a different chemotherapy backbone of carboplatin with either standard paclitaxel or nab-paclitaxel, and this was alone or in combination with pembrolizumab in patients with any degree of PD-L1 expression, and this also demonstrated a highly significant improvement in overall survival. The trend was strongest overall in the patients with more PD-L1, but this study is going to change the standard of care, and I believe justifiably so. And so we will see that for many of us, the leading question is going to be pembrolizumab monotherapy or in combination with chemotherapy. And that, in my mind, is going to be based on the level of PD-L1 expression, and I'm going to be most inclined to favor pembro monotherapy for high PD-L1 of 50% or greater, about 30% of our patients. And for most of the other patients, I will favor a combination with pembrolizumab based on the information we have now, and it's just going to be dependent on the histology. If it's non-squamous, favor a carbo-pemetrexed regimen. Interestingly, in Keynote 189, there was a little more of an issue with nephritis, so I would be a little more hesitant about cisplatin in this setting. And I personally would favor carbo and nab-paclitaxel with pembrolizumab for patients with advanced squamous lung cancer and lower level or negative PD-L1. Now, notably, there are some other studies emerging with other platinum doublets or even the same platinum doublets in combination with other checkpoint inhibitors. So I don't think that the results are at all exclusive to pembrolizumab, but it just so happens that the data we have at the moment are strongest with that. These are also easy to administer, generally very well tolerated, both for the chemo backbone and for the immunotherapy. So I think that in the future we'll need to see whether any of these other combinations of chemo and immunotherapy give us a reason to supplant the ones I've just talked about, or stick with this as the way to go if you're thinking about combining chemo and immunotherapy. And of course, one advantage of doing that combination of chemo and immunotherapy is that when we aren't sure which modality is more likely to work, perhaps both will work synergistically. At least this way, we ensure that all of our patients who start with chemo and immunotherapy will get their opportunity with two of our best treatment approaches, rather than having them fall off a curve if they progress after 6 or 8 weeks and never get a chance with the second line approach.